Thank you very much for those that are still here. What we're doing now is an experiment. And the experiment is to have a round table where there's no table and it's not round, where we have basically all the speakers, and I have a number of questions or points that we would wish to discuss. That's going to be very difficult, obviously. And so what I thought what we could do is just pick out one or two. I'll ask all the panelists to chirp in whenever there is something that they would like to contribute. I have the task to probably start asking people to comment to some of these questions. And then you in the audience, please also just contribute. Whether we go through the 101 questions that I have here, or whether we are stuck with question number 3, we will end up finishing the session on time, because I'm between here and the upper row, and obviously we can't delay that. But for the time being, what I'm going to give is just some microphones, and then you can move them on as you wish. So some of the questions we have prepared in the management meeting, known what was going to be presented today, and what we think from the BRCCH is something relevant to be discussed. And the first question is really giving our pediatric research focus of the BRCCH and looking forward with the knowledge of how we came to the point where we are now. What are the greatest expected progresses that we foresee with today's knowledge and probably a certain amount of hope? And so I'd like to start with Burcu, who has basically given us a couple of tools and projections and how these could be translated into clinical practice.
I find all of these questions very relevant to therapeutics. And for me, it has been a long journey doing a lot of theoretical work and using the data that I could find that could fit to my question. Now, I think for me, BRCCH, this entire collaboration is very important because then I will be working with medical doctors and this FIST-TPH and all these collaborations where I can actually have access to both the medical wisdom and also the data. And I think these kind of theoretical foundations can be really turned into a lot of translational studies. So I'm really excited actually to put that in practice. So my expectation would be like to see any kind of prediction of my work to turn into clinical translation. So that would be really exciting.
So if you think about this translation part, what are the elements that you think would need to be developed in order to reach the potential of this translational capacity?
I think the communication has to be two-way. So until now, it has been always like me going and asking questions and getting the data and doing my thing. But then it was a little bit hard to communicate it back to say that, okay, these are the things we can do. And then having open-minded people that would like to test it in clinic or test it in vitro or so forth. So I think when we have the communication two ways, that will be very useful because it is important for also these kind of work to be received by people who are doing the clinical trials and doing the pet lab stuff. So, yeah.
Well, I think we'll pick up on the second point, but probably if I could ask Emma to comment on, from your perspective, where do you think we should be so that we, in 10, 15 years, and we look back and say, well, we've really moved the needle from your research and what you had presented?
So I think one of the striking things for us was that we've been working on the best studied bacterial infection ever. And we're still we're still coming across novel biology that's extremely important for developing vaccines, for example. And I think that should be a warning sign for everyone that what we still need to work on actually is this huge amount of data generation. So there's fantastic tools, I think, that have been talked about here for analysing data and for massively accessing big data. But the other side of this is that we still need to keep generating that data. So the more these tools develop, the more pressure there is on the wet lab scientists actually to get these very high throughput analyses of things like bacterial glycans that are still a complete black box, and there's about maybe 100 good quality structures of these things out there, which isn't good enough to train any model anywhere. So I think the next big steps we have are just to keep ploughing through and actually get this data, and at the same time be working with the things that we already know with clinicians in the right places. With Swiss TPH still represented here, that I've had fantastic conversations with people during the day. That we have actually now candidate vaccines for some infections that we know are big problems particularly in low resource settings, and actually really start to work with clinicians to push those things out and get past regulatory, which is going to be fun.
So without a doubt, I fully would agree. And looking back, hopefully it would be great if we have vaccines against emerging but also known and persistent pathogens. Now, you mentioned data, generating more data, and with that, obviously, also data quality. When I started studying medicine, we were told that 50% of the information to be provided will be wrong. That's the good part. The bad part is we don't know which 50%. So I hope that this has changed, but it brings us back to the point which I'd like to ask Annie, is how can we now, with that flow of data, make sure that we are actually operating, introducing, using, and working with the correct data? Particularly if we go back, and this could have been a question to Michael Moore, if we go back and use generative AI platforms that test this information and integrates it where we don't really know whether it is actually the correct one.
Mm-hmm. Well, the first question is about actually just knowing what data you've trained on. It's about opening the data. We don't know if the right data or the wrong data has been in there if we actually don't see the data at all. And this is the state of most LLMs out there. Most large language models and most large models that are especially coming out from the proprietary systems or being open weights, we actually don't know what it's trained on. So it really is important that we make an effort to index the data that we are training on, and when we've got large data sets, to make an effort to combine them in a way that is indexable and searchable, and to work together to do that. I think it's important. The Swiss AI community that has been developing the Apertus model, for example, has made a huge initiative in this effect. And wouldn't that be interesting? Wouldn't you do that if you had the opportunity to just go and see, what does this model know about me? And to actually go and look up your name and just to see what it's trained on? You would do that with your glycans as well, right? And this is something that's actually very practical to do. There was a nice initiative that has started that I hope that I see more of, where there was a smaller open model by the Allen Institute, I think. And they made this initiative where you could go and ask a question and then trace back the answer to a specific data point that was used for the training. And this is wonderful. These kinds of transparency tools are really something that we need to focus on as scientists, because I think we are here for causality, for evidence, and we're relying a lot on tools that we don't have any traceability of. And I think we should set a standard that that's not acceptable, and make sure that we invest in those kinds of tools. Yeah.
Maybe I can just add to that. I think it's not only about what data is wrong, but also just making sure that it's not incomplete, as in that the whole story is represented and everybody's in there, because otherwise it just becomes an incomplete story. Even if it's correct in one, it's correct for premature babies in Basel, it may not be correct for other populations. So just making sure that the whole picture is there.
So I think this is a very good point, and we'll get back to the selectivity of the data that's out there, and that it basically comes from one particular part of the globe at the moment. And we need to undertake big efforts to not only democratize the information, but also to feed the information from across the globe. That was question number one. We're nowhere yet. Yeah, here's a question.
Sorry, just to get in there on the complete data. For me, an elephant in the room is that it could be on purpose, but nobody today spoke about sex and gender in their research. So isn't that also a huge trap we may fall into, feed models by not really looking at was the mouse, was it male, female, teenagers, do they identify as whatever? I mean, that for me is a big elephant if we miss out on that big part to not really have our data based on sex and gender.
So that's an important point. I think recent years have shown that this is not a white elephant in the room. So for example, the NIH for mouse experiments now requests that you come up with a rationale why you use only one over the other sex. We know from HIV studies, for example, that gender matters very much in the immune response, for example. So I think it's on the table, but you're absolutely right. We have been so far, and other people have already heard that from me, we have been very much focused on pale male stale, and we have to move away from that, without a doubt. I think one of the questions that came up in the initial responses to these very general questions was interdisciplinarity, working together, and I think between different disciplines. And I think this morning we heard a very striking example of a surgical field that has adopted image analysis and engineering to adapt a system to solve problems, which, for those that were around yesterday, then also heard that it has social implications in the country, for example, India, where the cleft palate therapeutic procedure was introduced. So I'd like to ask Andreas and Barbara as to what is the good ingredient for two different disciplines to start to interact and come to a common language, if I may say it like that.
May I start? I find with Barbara somebody who really has also the same interest of opening a new book, serving the children, and not just that she already had a tool and she was just happy that somebody is coming and say, I have these patients, and then the one who has the technology says, oh, that's nice, now I can also apply my technology on these patients, probably for one project or for just getting one funding. It's more, it's really the wish of making a path together beyond this one project or this one funding. This I really felt, and this is, I think, what makes us now also moving on.
Yeah, absolutely. And I can also add, that this close collaboration was really crucial in the project. So, I mean, we have in computer graphics, worked on digital humans for 20, 30 years, and there is a lot of technology around actually, but you cannot just take them and use them in the clinic. So we really need to understand what the requirements are, where the limitations are, for what these technologies can be useful, to adapt them accordingly and to then really make it usable in the clinic. So I think this is working closely together is the key in such projects.
So trying to find a common language and identify a problem to which both sides can contribute while understanding what each party brings to the table. Another question that I had written down was about scientific barriers, and what all of you in one form or another have encountered, but particularly because we are a pediatrically focused center, what are kind of the solutions in order to overcome them? And so, Kirsty, I wanted to ask you, because you see both sides, you see the technical side and you see the clinical neuropediatric side. Is there any advice?
So the good thing about being a pediatrician is that you're not afraid of children. That's a very helpful start.
Or then you have to stop being a pediatrician. Yeah.
You know what? The children are complicated to research because you have to explain to them in ways which are age appropriate, and you have to interact with them in ways which often requires reassurance that is not necessarily within your own information to give them. So you can give them reassurance based on what you think they need, but really the key thing that changes everything is the mum. So in working with mums, I've found that we've been able to solve all sorts of different problems. So let me give you a concrete example. So getting a child to sleep is not, mums in African contexts tend to put their children on their back with a blanket, and whereas babies in India might be put in a sling, or and European mums may need a very quiet, dark, separate room with no noise for their children. So what you need is what the child needs, and so actually a child doesn't exist in isolation. They exist in the context of their immediate caregiver and family and environment. And so thinking about them and thinking about research as needing to engage with both of those layers, and sometimes the larger societal and community layers, really makes a difference to how you approach things, and you have much greater success when you do that, because it's going to relate to how the child is used to being, and you explain to them in ways. When you're doing genetic tests with children who are able to understand, you have to think of examples that they can relate to, and you do that by speaking to families and community members. So I think I'm going on a bit, but speaking to the mums and understanding how things are done in different environments is what is needed. Is that what you were looking for?
Oh, I was looking for whatever came. So no real expectation, but it basically leads to a little bit to what Günther and Ariana are doing, particularly if you start to think now not only about Peru, but you were interested in doing the whole thing in Colombia, you were thinking about Mexico at one point. So can you just give a little flavor of the cultural differences that Kirsty just mentioned for your work?
Yeah, when we started, it started as workshops in Guatemala, and we quickly realized like this is not scalable, because moms are like coming together. And I think going to your point, one of the things that really motivated me to keep going was like this insight of, it doesn't matter where are you from, what country or what context, you want the best for your kid. When you connect to play, and it's not that hard, and you have a lot of powerful tools within you to transform a child's life. So now we are in 9 different countries, actually, including Mexico and Colombia. So it has been very insightful also to understand that within one country there could be multiple cultures. And I think that's one of the jobs AI can do really well when performed ethically, because it has really helped us contextualize faster but with the right safeguards of how do we do this contextualization with the voices of the people that are gonna use it. So I think AI can really truly help with contextualization, but it's not translation. It's, you have to give the AI the role that deserves within the cultural context and the voices of everybody.
So I think this answer just asked for Melissa to comment on AI and contextualization from an ethical point of view.
Yeah, I think about that in a number of different ways. One is we've talked a lot about representation, so it needs to be exposed to the content in order to learn appropriately. That's one step. But then, as we've also discussed, it has to be the right content. There's a lot of outdated research that's still out there that has still been ingested by these models, and without knowing causality, they can replicate that and may not always be transparent about the reasons why it's replicated. So understanding that context is really the role of human reinforcers. And so a lot of that context-specific learning is where you get a lot of value add, like the example that was spoken about today. And I think that one of the things that is a challenge to that is in the rush to translate. Very often people will kind of go to, well, LLM as judge is faster, and we don't need to do human reinforcement. Or you might have, I come from a very small hospital where in one of the cases, we only have one person who is actually the clinical expert who can validate the model outputs. So how do we separate that? So there's a lot of challenges to doing this, but there are ways to doing it really well. And then the last step is verifying the actual performance of the model in different contexts, because we see that the prospective ground, that's where our models get eaten for breakfast, right? We can build lots of different models and products. It's in the translation where really the critical effort is and where there's a high failure rate. The better a job you do at the beginning, the more that you minimize your risk of failure down the end. And very often the teams that try to rush to the end don't get the successful translation. So front loading all of that work, it seems intimidating, and a lot of, AI groups will kind of look at, you want me to check every one of these? You want a person to tell me that all of this, but that is what leads to a much better product in the end. So there's different ways that we can think about the fairness and context coming in, but really it is valuing the human expertise that we have and being adaptive as our expertise evolves over time.
Thank you very much. Let's shift gears a little bit, because one of the talks, or several of the talks that we've heard today, were about innovation. And innovation is something that has a lot of moments where innovation seems to be between a rock and a hard place, being in the capacity to develop it, or then in the translation. And so my question really to Chase at this point is, how do you perceive the current innovation landscape for health technologies, and possibly in particular pediatric aspects? And I ask that because, as Chase has mentioned, he has been involved in creation of companies and has probably had a good spoon of medicine as to what the world outside there wishes to support.
Yeah, so I suppose a few things there. Okay. So in general, when it comes to innovation within healthcare, I'd say I'm still regularly surprised, amazed at the innovation taking place and all the different angles it can come from. So if anything, I haven't felt that that's entered any sort of rut. It's more that these innovations take time, and you always go through this process of extreme excitement only to realize the real limitations, drops back down, and eventually comes to some middle ground. And every technology is going to go through that one way or another. And if anything, it's been fun seeing all the different starting points that have led to these innovations. Sometimes it's very much focused on the specific problem. Sometimes these innovations come out of nowhere, which admittedly is a big part of my own work on CRISPR, that we never would have envisioned having this specific protein with an RNA that can go in and cut DNA and edit it at specific places, but that's what we have. Now, in terms of working towards, I think, the relevant problems of the BRCCH within pediatrics, and caveat is that this is an area I'm still learning about, but overall, there are these disconnects between the real unmet needs, especially outside of the global north, and the drivers for innovation. And I've certainly run into this issue many times in thinking about molecular diagnostics, that from a market commercialization standpoint, it's a massive uphill battle, particularly to attract the capital that you would need to really develop real products or have those of interest from the big players in the space. And that kills a lot of ventures and efforts. And yet there are still these very real unmet needs in the global south, in low and middle income countries, that are desperate for these sort of solutions. And so to me, that's still a massive disconnect, but to the credit of the Botner Foundation, the willingness to put real money towards working towards these solutions is hopefully a catalyst, but it requires some pretty major efforts and investments to see this happen. And it's still a question in my head of what it'll take to really see these fully translated, but hopefully just one example at a time where you see the success that can be built upon. But was very much encouraged by a lot of the examples here today.
So if I just could expand that slightly, and the microphone goes to Randy. So when we looked at your MIP early on, there was a collaboration with pediatricians, gastroenterologists in Zimbabwe. Here you had a technology, you developed something, you saw the clinical need. It was about children malnourished, very high frequency in and around Harare. Can you comment a little bit of how you thought that journey, what you have done, gets closer to the clinical question that was part of your MIP in the first place?
I will do my best, and I will also try to connect it back to what Chase was saying about, or your question about innovation, bottlenecks, and hurdles and whatnot. I think we presented today on our progress towards something that on paper should help in these malnourished contexts. So malnourishment is because you're not getting the food and the nutrients you need. Sometimes if you get the right food, you don't have the microbes to, digest it, or you don't have the machinery to absorb it. So there's a lot of layers going on. So we thought that our tool could allow us to kind of dissect these in different ways. And so today I showed you just one micronutrient, which we hope to expand to a large number, which would get at, okay, if they're malnourished, why? Is it just calories, or are there particular facets of the diet that we can untangle it? And we showed you this diet experiment about, they like sugar acids if the nutrients aren't correct. And so Andrew, our clinical collaborator, is pretty confident that this is a nice signature of what a caloric insufficiency biomarker could look like. So we think we have caloric insufficiency markers, and now we have specific micronutrient deficiency markers. And so I think, as we add more and more of these layers and add more and more complexity, I think we might be able to address pretty hard problems where it's hard to pin down exactly where the deficiency is. And maybe, fast forward however many hundreds of years, if we have a campaign to detect it before it becomes a problem, right? Because that's part of the issue, is if they're already stunted, that's hard to correct. So if we could have campaigns to figure out deficiencies, what, where, why, what can we feed them, what are they receptive to on a personalized basis, I think one could maybe, draw a path to get there. But there are definitely many hurdles to get there. So, appropriately coined the Valley of Death. Academic innovations, not many of them make it to translation. I think innovation is what academics love and do extremely well. We like really great new concepts, but it's very hard to take a new innovation that is just so new and translate it. Why? Lots of reasons. One is that, the regulation might not be there. It's just too complicated. For an academic, we rather go do something conceptually interesting rather than the grind of translating. It's really hard. We're trying to run clinical trials with our cells and healthy human adults, and we're working in a bacteria which has been in people for hundreds of years, and yet the regulation is really slow. It's hard to get feedback. And also, it's hard to get money for things that take a lot of time for something that's so radically new. If you go talk to an investor to say, I'm going to take a bacteria and diagnose someone, they're like, hold on, this isn't an antibody. They like to fund what works and what is known and where things are clear. And so there's lots of hurdles. I could keep going, but you want to transition.
No. I just wanted to add, it's not only what works, but it has to work in the next 10 minutes. Anything that's long-term becomes an additional hurdle. And particularly if you start now to think of the data that we generate and the interventions that in the pediatric age group are necessary to be undertaken, we only probably know later in the trajectory of life whether we've done the right thing. And so that longevity view is part of what pediatrics is all about. And funders, but in particular also VCs, they don't have that patience, in my experience, and that has become from my personal point of view, a very frustrating point of view. If you can't measure it in the first 90 days after an intervention, why should we ...
I just wanted to comment on that because I consider myself like a social entrepreneurship, right? So it's very weird because I feel like I have to talk two languages, and now the academic collaboration, like there is one language with the VCs and acceleration and what's the next thing, you're optimizing for revenue. And in the academic world is so different, or in the impact world is so different metrics. So there is this tension that, especially in pediatrics and long-term impacts, is hard to navigate.
Yeah. So that leads me nicely to the next question, and that is, within pediatric research, what has been overlooked in the age of AI so that we can bring data to a suitable translation and into, in the end, changes due to clinical uptake? And that's obviously a question to you, Sarah.
All right. What has been overlooked? I think sometimes we try to use data in its best form, right? We try to centralize data. We try to tackle this problem of limited data by going to many institutions, centralizing it. And I'm not saying that we shouldn't do that, but I think it's important that we also build solutions that can live with the reality of the data, of the environment where these models should be used in the end. So in clinical practice, as I was mentioning as well about missingness of data, how can we effectively make use of this added information, that this piece of data especially is not there, that this also holds information, for example. So I think in this context, what is really needed is still an effort to invest in curating more data, also data that we maybe underestimate, because we tend to use the data where we already think, this is going to be relevant, but maybe innovation can really come also from the missing pieces that we don't have collected at this point. I strongly believe also in using mechanisms like combining techniques, not because it is scientifically the most interesting, but also to think really about what is the best for what I want to achieve, what really is the best computational solution. And maybe something a little bit outdated can really bring something new in this context, and also to harness this data most efficiently.
So, Noe, that is exactly now from the adult medicine point of view, and your complex system of sweat, perspiration being driven by a number of different things, from disease to, as we heard, temperature outside and food uptake. So how do you see that challenge?
Yeah, so I think there is the way where the clinician can help you out as well, like in which use case you need to be very precise, and there might be some clinical use cases where you can be less precise and aggregate data just to have a kind of a trend that in certain clinical questions will help your patients in a certain way. So I think it's important to understand where you need to have 100% of the data super precise in drug monitoring, for example. But if the question is did this person take the medication or not, it's 1 or 0. So you can be less precise as long as you detect the drug, so you know yes or no, and you already can have a kind of an added clinical value. I think it's important to understand where you need 100% completed data, super accurate, and where you can just aggregate data to understand the trend over 1 year or something, which could be helpful in prevention or other cases. So I think there is the clinical understanding of how to use the data could be very helpful just to bring a solution forward.
If I might actually add something small to that, I think it's also important to, clinicians asking the question and then collecting the data, but in the process also working with the people that will use the data or analyze the data. Because say you have money for 50 subjects and you have 10 time points, maybe if we talk about it earlier, then it will be better for you to have 10 subjects with 50 time points. So I think it would be great to also include people that will do the analysis afterwards, but not think of them as aftermath of it, but at the process of data collection.
I think that could probably also have a comment from you, Melissa, as to the data that is being generated. And going forward from what you said, with people being progressively thoughtful about what happens to data, are we running out of data in the future to be used for medical interpretation, diagnostics?
Well, so there is the concern about recursive collapse that people are speaking about, particularly with the increase of synthetic text that's now in our medical records. That might be a big issue in the future. I guess we don't necessarily know. But part of the reason that many platforms have prioritized engagement metrics is because they are looking for increasing examples of human-generated text that they can train from. And so I think as people are increasingly aware of these types of things, my main worry is that the practices that people hear about in the news, which are always the bad ones because you never hear about the good ones, we all kind of become shadowed by that. And the antidote to it is working closely with people from the beginning so that you build that trust over time, and it can change the dynamic when you go into the clinic. One of the top things that we get asked, particularly in the Australian context, where there's very strong requirements around consumer engagement, is parents will ask us, was there a parent who gave you advice during this study? And if we can say, yes, actually we have 4 parent co-investigators, they gave us advice from the beginning, we get a very different response. Same thing with young people. When I go in, the environmental impact question is the number one thing that they ask me about. And when I'm prepared to answer that and talk about what we're trying to do to mitigate that, it gets a very different response than if I were to go in cold. So I think that the more that we work with people directly throughout that process, the better prepared we are when we do go into clinic for the questions that we're going to get. And by answering those faithfully, we can increase the trust in a given AI tool.
That, I think, is an excellent segue to a next thought that we had entertained, and that is for digital health solutions, again, fed by contributions from patients in the pediatric age group, parents. For those solutions, where do you all collectively see here the limitations in scaling up and in employing it and making it sustainable and usable? And so that goes back to you, Annie, probably as a first question. How do we employ the tools that we have for a useful usage?
Yeah, well, first of all, if you want to be useful, you should measure the right metrics of being useful. And we can have data that's coming from labs and LLMs as judges and hypothetical scenario testing. But we actually need to understand how it works in practice, in the real world. So, for example, if you give a doctor an LLM and you say, use it to make diagnoses, and the doctor asks, what is diabetes or how should I treat this or something? And the answer comes back, oh, well, you know what you should do? You should remove both eyeballs, right?
Oh, that's a new method.
It is. And aren't you convinced, right? So we do need to understand how humans will actually react to bad information as well as good information in practice. Do they trust it? This is cultural. Will they follow it? Do they have the resources to follow it? Do they have the time? And so because it's so important to understand how a good response will actually behave when it's left out in the wild, we do have to test it in practice, right? Not everyone is going to go and remove the eyeballs. In fact, probably no one will. And so we have a different standard, right? That we hope, live to dream. There is cognitive atrophy. With using models, we tend to get a little bit more stupid. But and that's the official term. It's cognitive atrophy, by the way. So I think that it's really important that we care about how they behave in practice and that we do collect outcomes, and we continue to do that. This is expensive. So it comes to your question of sustainability. Very expensive to create trials and to go out into the field. We're doing like several of them now. So what we have to do is be more smart about like how we collect these feedback mechanisms. And we don't need a randomized control trial for every single outcome. But we do need some monitoring that we give feedback into the models when we do see some metrics that are worrying. So I think sustainability of that is important, and it actually needs funding. Right now, open models that are available to do this kind of stuff, they're not funded. And everyone thinks, open source, 3 guys in a garage, right? They'll take care of it. And for the first time, I think that these models are becoming so powerful and so useful in so many different ways that we are starting to feel the weight of our responsibility as a community to maintain them as a community at scale, at the same scale that we would have done for a big corporation somewhere. And I think it's really important that we take that seriously now. Not everyone, I think sustainability, for the last thing if I want to say like a last thing, fragmentation will ruin everything. If everyone has their little model that they're making, and we just fragment our effort, this is going to be the thing that really makes it unsustainable. Yeah.
And non-representation.
Exactly.
So that goes back to you, Kirsty, and a point that we picked up very early on. Where are our blind spots? And how can we basically avoid them in light of what just Annie said, namely a financial bottleneck? Nobody's going to support a clinical data acquisition, and be it just in physiological perspectives of healthy children in the global south, if there is not somebody who gives money. And circular, there is no money for that.
Well, I think that there's a growing community of people who know that it is absolutely critical that we do it. And the people who are motivated to do it find a way to do it. I think that it does require, I think that the mentality of we can't do it because there isn't money is not going to help us solve the problem. I think that we have to think of the best way that we can do the most with what we have and advocate for what we need to do it. Obviously, there are situations where we can, do a bit more, and there are certain places that are able to do a bit more because they've got more resources, but that should feed into it being more cheaper and be able to use some of these more scalable approaches in other environments where it may not be, where we're getting, where the equipment just isn't there, and so where the investment can be in things which are fit for purpose. And this isn't about saying people in Africa need less. It's about saying, what question are we asking, and what do we need to answer that question? It's not a 7 Tesla scanner. And that is well, obviously the 11T, but, we don't need that to answer these questions. And that doesn't make it less. It makes it fit for purpose. And so I think that helping people manage that kind of thinking is really critical. Yeah.
I want to add on that, if you don't mind, because I thought that was great. You know, we mustn't lose our ambition when we just go down to the south. I mean, like, well, from South Africans, of course, we are ambitious. We want to get the highest value of care, and we don't need to do worse. And actually, it's a huge advantage. I love it. We only work in low resource settings and extreme environments, and it makes you think differently about how you design tools. And what a pleasure it is to work under constraints like this, because you make more efficient tools. Who doesn't want a more efficient tool? And in the South, at least like in the global South, if that's the term that we're using here, about, you know, we own impact. It's such a wonderful place to work. It's so rewarding, and you can measure it. And I think that if people measure it like well, then the return on investment it would be so obvious. We're not like saving a doctor 2 minutes of their time, or you know, a disease that is like 0.0000001% of the population. There's really, really low-hanging fruit that is so obvious. It's a no-do gap. We know how to do it, we just don't do it. And for the first time, these tools are actually very, very tangibly just there. We can get them. So yeah, I think sustainability is measuring the stuff right. Yeah.
And just to segue off that, the learnings are relevant everywhere. As I said in my talk, there are places in every single part of the world that have less resources, and one can learn how to do what is needed in places, you know, in places that don't have enough and that are bound by those constraints by definition. And those learnings can go back into other environments, so they are globally relevant.
Okay, last one. I promise. I'm done. I promise. But just to say the model that we made for our low resource settings in Africa, you know who found it very valuable? The University Hospital of Lausanne. The opposite. Everywhere is a resource limited setting because everyone wants to spend less compute, spend less time, and making low resource tools is extraordinarily valuable across the board, and it should resonate with the Swiss community as much as it does elsewhere.
So I think on these very important words, I'd like to conclude the session. I would also like to mention here that Fondation Botnar, with its 2 outlets here in Basel, the BRCCH and the BIIE, I think have made a lot of the things that we've heard here, if not possible, so at least bring in the players, set them up for a journey where these 2 institutions can contribute to this. And with the change of the Basel Research Centre for Child Health from a granting agency to now a centre with a physical building soon across from the hospital, Children's Hospital and the Adult Hospital, and very close to ETH, we really hope that this contribution can be meaningful and step-changing. And so I'd like to thank all those that contributed here to this inexistent round table, but existent discussion, and I'd like to give them some applause.